Good afternoon, everyone. Today in our urology Viva exam preparation, we are going to discuss the scenarios on bladder cancer. Thank you for the trainee who has agreed to record this procedure, which will be a good revision and learning source for the future batch. Your time starts now. You have a 58-year-old gentleman presented with history of visible hematuria in your hematuria clinic. How are you going to treat him?
So I will assess this patient in a one-stop hematuria clinic with a cancer specialist, where I'll take a history, examine the patient, arrange some investigations, including a flexible cystoscopy. In my history, I will confirm the duration of this hematuria. I'll ask about associated lower urinary tract symptoms, if there's been any recurrent or associated urinary tract infection. I'll ask about any signs of anemia, such as tiredness, symptoms of metastatic disease, such as weight loss. I'll ask about risk factors for urothelial cancer, such as smoking or exposure to chemical dyes. I will document his past medical history, medication history, including anticoagulation. And I'll offer a chaperone and examine this patient. I'll examine his abdomen for any palpable bladder, examine the genitalia, and do a rectal examination to assess the prostate for any abnormalities. Following on from this, I'll send some urine for urine dip cultures, as well as cytology. I'll take bloods for full blood count, using clotting, and after appropriate counseling, I'll send off PSA as well. I will then discuss a flexible cystoscopy with the bowels information leaflet and proceed with this investigation. I would also arrange for upper tract imaging. Given that this is visible hematuria and it's 58, I will go for a CT urogram if he has a normal kidney function.
Okay, you said 58 age to be considered when you are planning CT urogram. Why is that?
Yes. So the Royal College of Radiology guideline advises that below 40 years of age to go for an ultrasound scan, but if they're 40 and above, to go for a CT for visible hematuria.
Why is that?
This is because of the radiation dose and associated risk of cancer. So the older the patient, the more likely they're going to have a urothelial cancer. Also, if a patient has a high radiation at a young age, then the risk of developing radiation-associated cancer is higher for younger patients. So these are the considerations.
Okay, so you are performing flexible cystoscopy, and cystoscopy picked up a 2 centimeter papillary lesion in left lateral wall. Do you think you can improve the efficiency of your normal flexible cystoscopy by any means?
So the efficiency or pickup rate of a flexible cystoscopy can be improved by photodynamic cystoscopy or blue light cystoscopy or narrowband imaging.
Okay, what do you mean by photodynamic cystoscopy?
So this involves administration of 5-aminolevulinic acid or 6 or hexalevulinic acid an hour before cystoscopy, and introduction of blue light at a wavelength of 375 to 440 nanometers, and the abdominal urothelium will appear red on cystoscopy.
Okay, what about narrowband imaging, how it works?
So narrowband images uses a particular band of light for cystoscopy, and also abnormal urothelium will appear differently, but I'm not exactly sure what the color changes with the narrowband. Okay.
Now, as I said, this patient has 1.5 to 2 centimeter papillary lesion in the left lateral wall. Both the ureteric orifices were normal. How are you going to proceed?
So I'll counsel this patient with a Macmillan nurse specialist, explain that there is a lesion in the bladder suspicious for a bladder cancer. I will explain that he requires a transurethral resection of bladder tumor to remove the tumor, but also yield tissue for histological analysis. I will counsel him regarding this procedure with the bowels information leaflet, discussing the risks, benefits, and alternatives, which in this case, there isn't really much alternative. I'll discuss the risk of infection, bleeding, bladder perforation with this patient. I would also advise that we will administer post-operative Mitomycin to reduce the risk of recurrence. If this patient is agreeable, I will add them to the list for a TURBT. I would also take the opportunity to request upper tract imaging in the form of a CT urogram.
Okay, his CT urogram is normal. What is the evidence of Mitomycin?
So a meta-analysis by Sylvester et al. Showed that with the post-op administration of intravesical Mitomycin, there is a relative risk reduction of 39% of risk of recurrence, absolute risk reduction of 12, and absolute risk reduction of 8.5, and a number needed to treat of 12.
Okay, so how will you give Mitomycin? Let us assume that you are doing a monopolar TURBT. The resection went well. How will you give Mitomycin?
So Mitomycin is given immediately post-op. It's reconstituted with 40 milligrams of Mitomycin in 40 or 50 mils of saline, and it comes in a closed system, which is instilled into the bladder. With all the cytotoxic measures of PPE applied, and it's left in the bladder for an hour and emptied.
Okay. What precautions you will inform the team in the recovery?
So I will inform them that this patient has a cytotoxic drug. It needs to be disposed in a cytotoxic bin with appropriate personal protection, in the form of gloves, apron, and visors to be worn before draining and emptying this Mitomycin.
Okay. His histology is G2, high grade, pTA TCC with muscle present in the specimen but not involved. How are you going to treat him?
So, according to the NICE risk stratification, this is the intermediate. This qualifies as intermediate risk, and this. So I will discuss him in the MDT. An MDT will likely recommend, given that there is good muscle specimen, which is clear of tumor. MDT will likely recommend a 6-week course of intravesical Mitomycin to reduce recurrence.
So what is the evidence behind that?
So again, this comes from the meta-analysis from Sylvester.
Okay. So how are you going to arrange further follow-up for him? So
the follow-up of this patient, given that it's intermediate risk, will involve following the administration of Mitomycin. It will be flexible cystoscopy at 3 months, and then 6 months, 18 months, and annually after that.
So how long you're going to follow up him?
For up to 5 years.
Okay. So when the patient comes for review, is there any difference in your approach compared to the normal flexible cystoscopy? Anything you need to do more, or what is your aim during the first flexible cystoscopy review?
So my aim in the first flexible cystoscopy is to carefully look for any evidence of recurrence. This patient would also benefit from urine cytology as well to look for any abnormal cells. And so I will perform a cystoscopy as well as send off a urine cytology for this patient.
Okay. How this cytology works? What are you looking for in cytology?
So cytology works on the principles that abnormal high grade or bladder cancer cells are shed in the urine, and this will be analyzed under the microscope, looking for cellular features of malignancy, such as ATPA or raised nucleocytoplasmic ratio to categorize if the cells are abnormal or not.
Okay. What do you mean by papillary urothelial neoplasia of low malignant potential?
So this term came in following the most recent classification of urothelial or grading of urothelial cancer by WHO, and it is the lowest risk of abnormality of bladder cancer.
Okay, good. So it's time's up now. Well done. Basic scenario, box standard. You have done the same scenario with us before. So nicely done. No major concerns. You have picked up the risk factors like smoking, and the few things what I can say is sending urine dipstick and urine culture. You just said in one breath. Urine culture only if urine dip is positive. If urine dip is negative or normal, no need for urine culture.
Okay.
Yeah, you are correct with the age cutoff was 40. So less than 40-year-old. Number one, chances of finding urothelial cancer is less. Number two, we don't want to expose them to radiation, which will have long-term effect for a young patient. So that's why we prefer ultrasound. Of course, if ultrasound is abnormal, we will go ahead with CT scan. Read about narrowband imaging. Better to bring out the nanometers and various wavelengths, etc., like how you have said for the green light cystoscopy. 40 milligram mitomycin in 40 ml of normal saline. You said 40 or 50 ml of normal saline. Just stick with 40 ml of normal saline.
Okay.
Like any other mitomycin in the follow-up, you can keep the mitomycin post T or BT for 2 hours. And if the patient is nicely awake and able to tolerate, you can ask the patient to change the position every 30 minutes, more the merrier. Because we are not aiming only the T or BT scar, we want the mitomycin to touch the full mucosa, including the
bladder.
So 2 hours with rotations if possible, especially early T or BT, it's quite difficult, but if possible. And as you said, warn the recovery team that this is cytotoxic drug, and you should bring in the purple topped yellow disposable bins. That is the code for here. Usually I think it's international, so it should be the same all over.
Okay.